Welcome, everybody, and thank you all for joining us from Ontario and across all Canada. It's really a pleasure to be able to bring this webinar session with Dr. Teitel to you and to bring the community together during these pretty interesting times. So, as I said earlier, my name is Boyan Piernat, and I'm the Regional Coordinator for Member Support and Services at Hemophilia Ontario, and I'm going to be moderating today. So, since this is a new technology that we're on and we're just getting started with this, I'm going to give you a quick overview, one of the session we're going to be doing today, and then a bit of troubleshooting. So we're going to begin with some opening remarks from me, as I've already started, and then we're going to follow it up with Dr. Teitel's presentation. And then we're going to finish with a question period. And question period is going to be broken into two parts. If you noticed earlier, we asked people to send in advance some questions and to allow Dr. Teitel the chance to prepare to answer those questions. So those will be the ones we answer first, and then we'll open it up to everybody to send in their questions. So throughout the process, you'll be able to send in your questions, and we'll have somebody on the other end collecting them and putting them together to be presented at the end. Now, obviously, we have a limited time today until 6:05, and we'd like to answer all of your questions if we can, but if we're not able to get to some of them, the option we're going to have is for you to get in touch with me, anything that we're unable to answer, through my contact info, which you can find either on the Hemophilia Ontario website or in the invite that was sent to you for this webinar. And you can send me your question, and I'll do my best to connect you with the resources. If there are some questions that we notice that there's a pattern and questions that need to be answered, we'll look for maybe another opportunity to put together a webinar with somebody who can answer those questions and invite you all again. So without too much further ado, I'd like to introduce Dr. Jerry Teitel, for those of you who don't know him. He's been the medical director of St. Michael's Hospital Treatment Center since its founding in 1983. He's the hematologist, and he's worked with the bleeding disorders community since hemophilia clinics started in Canada, essentially. He's been the president of the Canadian Hematology Society and the Hemophilia and Thrombosis Research Society of North America, and he has written or co-authored approximately 100 peer-reviewed articles and book chapters in the field of coagulation and bleeding disorders. And I'd like to welcome him right now. Thank you for joining us, Dr. Teitel.
Thanks, Boyan. Is my audio okay? Can you hear me?
I can hear you. You sound pretty good on this end. And I will actually, very quickly, just before we get started, I wanted to do a quick poll for people just to see responsiveness, if you don't mind.
Go ahead.
Okay, so you'll see a poll jump up on your screens. Just a quick question, a fun question, asking you where you're joining us from, since we've opened this up to the whole country. I'm going to launch right now, open the poll, and you can start by clicking, and I'll give you about 30 seconds to answer, and then I will be closing the poll. Okay, we've had about an 80% response rate. For those of you who haven't voted, it's too late, and I'm going to close it now. All right, I'm going to share it quickly with you. Looks like we've got a great showing, 80% almost from Ontario, about 20% from the rest of the country, and even a couple from outside. That's great. Wonderful. I'm glad that you're all engaged, and at least 80% of you are looking at your screen. So next slide has some instructions on how to ask questions on your right-hand side, and as we go, and then if you go to, I'll let you take a look at that for about 10 more seconds. And last, I mentioned it before, but I'll mention it again, that we are recording this session. None of your names or anything like that will be available for the recording, so you don't need to worry about anonymity. And we will be posting this on the website afterwards. All right, without further ado, thank you, Dr. Teitel, and thanks for your patience with that interlude.
All right. Thanks very much, Boyan, and thanks, Hemophilia Ontario, for asking me to participate in this. And I also want to thank Novo Nordisk and VTran for sponsoring this. So if I can have the next slide, please. Here are my disclosures. And the next slide, I hate to start with this, but I'm starting with a disclaimer. I'm going to let you know that I'm reminding you that we're talking about COVID-19 as it applies to patients with bleeding disorders. I am not a COVID or a coronavirus specialist. I'm not a microbiologist, a virologist. I'm not in infectious diseases. So I can only respond to or to speak to how this pandemic and how this illness is affecting people with bleeding disorders. So I'll confine my remarks to that, and I'm not going to be able to go outside my area of expertise, and anything I say should not be construed as being specific medical advice for any individual. So now let's get on to the actual talk. The next slide, please. So COVID-19, which is the name of the disease that we're all focused on these days, what are the risk factors for developing it? Well, first of all, we're all at risk, and we're all at risk because the virus that causes it, which is called SARS-CoV-2, is new to our species. So none of us have encountered this virus before, so none of us have had the chance to develop immunity. We don't know how immunity is going to develop. So what do we know of the risk factors for developing more severe COVID? The first and foremost, it's advanced age. That is the most important risk factor, which is more relevant to people like me than to most of the people listening to this call. People with chronic lung or kidney disease, with diabetes, with advanced liver disease, cardiovascular disease, smoking, and obesity. Those appear to be risk factors for severity of COVID. And you'll notice from that list that these are not specifically relevant to people with bleeding disorders, other than perhaps those who have advanced liver disease related to hepatitis C, or patients with acquired hemophilia, which is an autoimmune disease of older age, which some of you will know of. And the evidence, and this is relevant to some of our people in our community, the evidence does not suggest that HIV infection is a risk factor for COVID-19, or at least for severity of COVID-19 or for susceptibility to COVID-19. So the next slide, please. So what about COVID-19 in people with hemophilia? Well, the first statement I'm going to make is one that I think I can say confidently, and that is it has no doubt occurred. Given the frequency of hemophilia in the population, about 1 in 10,000, and the spread of this pandemic, I'm sure people with hemophilia have developed COVID. There's not a whole lot, there's very little, almost nothing so far in the literature about that, but there is one interesting case report, which I'll give you a little bit of the details of on this slide. And this is a 35-year-old man with severe hemophilia A, a resident of Wuhan, which was where the pandemic got its start. He developed symptoms consistent with COVID-19. It was confirmed by swab. He was probably infected by a household contact, and he was treated at home. He was not hospitalized. He was given supportive care. This was early in the pandemic. They used both antiviral and antimicrobial drugs, which are not conventional for treating COVID. Nevertheless, that's how he was treated. And he recovered fully. He had a full recovery after about a 2-week illness. And importantly, during his illness, the authors who reported this did not report any bleeding events and no hemoptysis. For those of you who don't know the term, hemoptysis means coughing up blood. And that's particularly relevant because, of course, COVID-19 is a pneumonia-like illness. So it's an inflammation of the lungs, and yet this patient, this young man with hemophilia, did not cough up any blood during his illness or recovery. So that's at least one example of someone with hemophilia who we know developed COVID-19. The next slide, please. This refers to the nature of the coagulation system, the blood clotting system in people with COVID-19. Now, in fact, the coagulation system, the coagulation proteins such as factor VIII, factor IX, and other coagulation factors as well as the platelets, are often excessively activated during COVID, and in particular in those with severe disease. And in fact, one of the key indicators that is being used to monitor the severity of the disease is a marker of an activated clotting system. That's something called D-dimer. Most of you will not be familiar with that because it's not something we would typically measure in people with hemophilia. It's a marker of thrombosis, of blood clotting. So in fact, thrombosis, excessive clotting, rather than bleeding, is the major concern with respect to coagulation during infection with COVID-19. These blood clots usually occur in veins, although occasionally there have been reports of strokes, which are blockages in arteries. And almost all hospitalized patients with COVID are given a so-called blood thinner, a heparin-like anticoagulant. And in those who are severely ill in intensive care or ventilated or with proven blood clots, these are often given in fairly high doses. So let's go on to the next, please. So what about bleeding? Is that a concern at all in COVID? Well, in general, if someone with this illness is going to bleed, it's not going to be spontaneous. It's going to be provoked. And it's going to be provoked by something such as the need for intubation, that is putting in a tube for ventilation, or by biopsies. And in fact, if you look at the clotting factors in people with COVID-19, factor 8 is typically increased. It will go very high in patients with active COVID-19. And in fact, we see that in any acute illness, people who have normal factor 8 to begin with, it will usually rise as what we call an acute phase reactant, as does fibrinogen and some other proteins in the blood. Now, someone with hemophilia A, we're not going to expect to see a rise in factor 8, but if you have hemophilia B or von Willebrand disease, you'll probably see a rise in factor 8 during COVID-19. That's not pathological, it's a normal physiological response. The platelet count in many viral diseases falls, but in fact in COVID-19, it's been observed that the platelet count tends to fall only very mildly in most patients. Although in those with severe disease, particularly those who are on ventilators and intensive care units, there can be a more drastic fall in the platelet count, and these patients can also have a fall in clotting factor proteins. But that's really only in a very small minority of patients with the most severe disease. And in those late stages of disease, bleeding can become a problem. But I'll again emphasize that thrombosis, blood clots, rather than bleeding, is the major coagulation disturbance that has been observed during the COVID-19 pandemic. And the next slide, please. So what about hemophilia-related concerns? Now, I'm putting this up from a very nice editorial that was published recently. There's a citation at the bottom. And the authors of this were Cedric Hermans, who's a very prominent hemophilia expert based in Belgium, Alain Weil, who is, as you know, the president of the World Federation of Hemophilia, and Glenn Pierce, who's the vice president medical of the WFH. So they co-wrote this editorial in Hemophilia. It's available online now. And I'm abstracting from their editorial what they consider the major potential concerns for people with hemophilia and related bleeding disorders during the pandemic. And the first and foremost, of course, is ensuring access to hemophilia treatment products. So what might be the stress on that? Well, we're all concerned about potential disruption of supply chains due to stress on transportation links, on pharmacies, blood banks, home delivery companies. Those are not involved in delivery of hemophilia treatment products in Canada, but they are in other countries. Just as we're concerned about supply chains for our groceries and for pharmaceutical supplies and others. So those are potential risks. Has not occurred, thankfully. We've got good supplies and we're not anticipating disruption, but that is something we have to keep our eye on. Potentially, there is a theoretical reduction of output at production facilities. Again, potential but not actual. So for example, if in a recombinant protein production facility, output had to be decreased because of distancing requirements, so reduction in the workforce, for illness of workers at that facility, theoretically there could be a reduction in output. and certainly a reduction in plasma donation. People are reluctant to leave home for anything now under the current restrictions, and we are seeing reductions in donations at plasma and blood donation centers in Canada and elsewhere. The other thing we have to be potentially concerned about is reduced access to medical care at hospitals and hemophilia treatment centers. Now, as I'll show you later in this brief talk, we have not had great strain, fortunately, on our healthcare system in Canada, but it has been the case, as you know, in other countries, in the United States and in Europe, and where there's great stress on the hospital system in general, that's going to impact hemophilia treatment centers. Certainly, interruption of recruitment in clinical trials has occurred during the pandemic. Cancellation of educational research activities. We have the opportunity, fortunately, to do events like this, but other events have been canceled or deferred. And of course, there's economic impact on all of us, not only on us as individuals, but on funding agencies. So as you know, in Canada, we're taking on, as in other countries, very large amounts of deficits and future debt. Now, I'm not suggesting that in any way this is going to affect funding for hemophilia treatment products, but this is what was highlighted by these experts as things to keep our eye on during the pandemic. We can go to the next slide, please. So what about the blood system and COVID-19? A lot of you still rely on plasma-derived factor concentrates as well as other blood products. There has, first of all, been no concern, I'll repeat, I said this earlier, about supplies of any of the clotting factor concentrates we use in Canada or plasma-derived products. And there has been no report of transmission of SARS-CoV-2, the causative virus, by blood products. And there was an interesting report recently in a journal called Vox Sanguinis that came from Korea, in which 7 donors, blood donors and plasma donors, who were perfectly healthy at the time of their donation, were later found to be positive for COVID-19. Now, the authorities immediately, of course, recalled all the remaining fractions that came from their donation, but 9 patients had already been given product, either platelets or red blood cells, from these 7 positive donors. They followed up on all the recipients, and sorry, there's a typo here. It should say none of the recipients contracted COVID-19. So 9 of those patients who received products from these patients who were asymptomatic at the time of their donation, none of them became COVID-19 positive. So that's an encouraging observation. A small report, but we're early days. So next slide, please. So what recommendations then can we offer for bleeding disorder patients during the COVID-19 pandemic? And this, I think, is probably a key slide here in this talk. First of all, we're encouraging all of you who are on home infusion to maintain a good supply of your home infusion products. Your hemophilia treatment centers are going to help you with this. At our center, we have been issuing larger than typical supplies, at least 4 months of supplies for our patients, to minimize the number of times you have to come down and visit us to pick up your product. Maintain your prophylactic infusion schedules. This is not a time to try to space out your treatments. Keep up your prophylactic infusion schedules. Treat bleeds promptly, any breakthrough bleeds promptly. And importantly, please keep up your infusion records up to date. So those of you in most of the country should be registered with MyCBDR to keep up your electronic infusion records. In British Columbia, if there's anyone from BC, you'll be using iChips, but whatever you use, make sure you keep those records up to date. That allows us to communicate with you. It allows us to know how things are going with you, and allows us to speak with you and give you advice if we see any blips in the typical usage patterns. Report any unusual bleeding events to your hemophilia treatment center promptly. We're doing now many visits by telephone or video. We're here at St. Mike's, we're running telephone hemophilia clinics. They're not great, but they're the best we can do now. But if you do need a treatment, or if you have a severe or unusual bleed, don't be afraid to come to the clinic. hospitals are not scary places now. I'm in the hospital now, and I'm not scared. None of you should be either. We're doing very rigorous screening for anyone who walks in any door of this hospital. You can't get by without being very extensively screened. Anyone who has any symptoms of concern is immediately diverted to our COVID assessment center. And everyone is wearing masks. I'm in my office, that's why I'm not masked. But don't be afraid to come to the hospital if you need treatment. We're still open for business and we've got plenty of room. And those of you who are on shorter acting products who have maybe been considering a switch to longer acting products, it's something that you may consider now, again, to reduce the number of visits to hospital. But that's something that we should consider on an individual basis. So can I have the next slide, please? So the last two slides here, just to give you a little idea of how things, I've been keeping this, this is my own homemade slides. I've just got two slides here to give you an idea of the course of the COVID-19 epidemic. This is Ontario data. You may not be able to see the numbers on the axes very well, but you can certainly see the shape of the lines. The top red line is new cases in Ontario from about mid-April to a couple of days ago. And you can see, although it's a little bit up and down, in general, the number of new cases is decreasing. The blue line in the bottom is deaths, daily deaths. Unfortunately, people are still, we're still seeing deaths every day. The numbers are reasonably stable with a little bit of up and down, but the number of new cases is decreasing. And the next slide shows something that I alluded to earlier, and that's the health system. How are we coping with the health system? And this is an interesting slide, something that I'm following closely. The orange line on the top shows the number of patients in Ontario who are hospitalized every day. So as you can see, that line's going up. So every day we are seeing a higher cumulative number of patients with COVID-19 hospitalized across the whole province. Now that's not still a very big number. That's not stressing the hospital system at all, but it is going up. And I think what that's telling us is that patients who are hospitalized with COVID-19 tend to stay in a long time. The average stay is 2 or 3 weeks at least. So it tends to be a nagging illness. It takes its time before people are feeling well enough to be discharged. Now the bottom two lines show, the green line shows the number of patients in Ontario who are in intensive care units. And the blue line is the number of patients who are on ventilators. And those lines, as you can see, those are pretty small numbers, and they're not increasing. In fact, if anything, they're gently going down day by day. So only a small proportion of the patients who are in hospital actually need intensive care or need to be on ventilators. And, you know, fewer than 200 on ventilators, and we've got, you know, probably 2,000 ventilators in Ontario. So we're nowhere near capacity. There's lots of give. We've got lots of capacity in the healthcare system. So I show you this just to reassure you that we're still in the midst of a pandemic, but the healthcare system is coping in Canada and in Ontario very well. So that's my last slide, and I will finish now, and we'll go on to the question period.
Thank you so much for that, Dr. Teitel. That was a great presentation. I know I learned a lot, even in this position that I'm in of trying to monitor this stuff closely. This was extremely informative and great to hear from somebody in the community. I think it's sorely needed, and I think with the numbers that we're seeing today attending the webinar, people are very curious to know how it's going to affect their health. So thank you. I think we can move on to the question period. I can read these out to you to do it like a conversational style, or if you'd like to read yourself, but I guess me reading it to you is probably a better way to go. So, all right, first question. Are people with hemophilia, von Willebrand's, or other bleeding disorders more susceptible to SARS-CoV-2 infection or severe COVID-19 disease? Are there any additional complications?
So I think the answer to that, I think, is no to both questions. That is, Are they more susceptible to developing disease? I think the answer to that is no. There's no reason to think that, unless, as I showed you in the first slide, one happens to have advanced liver disease or kidney disease or severe obesity, one of the other risk factors. Other than that, hemophilia, von Willebrand disease, other bleeding disorders don't confer a risk of developing infection, nor do they confer a risk of developing severe disease. Additional complications, you know, if someone was in hospital with bleeding disorder and we would probably be very gentle with replacing therapy because of the concern, as I pointed out, of thrombosis. We don't want to overcorrect someone and make them more susceptible to thrombosis. So are there additional complications? You know, we can manage bleeding disorders. We can correct that and allow whatever interventions or biopsies, et cetera, would need to be done. So I don't think we should anticipate other complications.
Okay, perfect. Question 2, if you have a bleeding disorder and HIV, HCV, are you at higher risk or more likely to have more severe COVID-19? Right.
You know, I did try to look this up before this talk because I anticipated that question, and we don't know a lot. And, you know, there was, I showed you some data, I made a statement in one of the earlier slides saying it appears that HIV is not a risk factor for severe COVID disease. And that came with a little bit of back and forth and a couple of letters in the literature. One investigator had seen a case of a patient with HIV who had severe COVID. Another one said, no, I've seen a couple of cases who did not, of people with HIV who had very mild disease. So the answer is we don't know, but we have not seen reports of severe COVID in large numbers of people with HIV disease. And of course, most people with HIV in the hemophilia and bleeding disorders community are being well treated and have negative viral loads, normal CD4 counts. In other words, their immune systems are pretty much intact. So we would not anticipate that. Hep C itself, I would not consider a risk factor unless there is really advanced liver disease. And that has been suggested as a potential risk factor for more severe COVID.
Okay. I'll jump in here and make a little addition. We had a question from a member, and I think it's worth reiterating here, which is why I'll bring it up. Their son is an essential worker, a frontline worker at a grocery store, and they're concerned for him having a higher risk, other than, I mean, the obvious higher risk of being an essential worker. And are there things specifically as a person with a bleeding disorder he can do to be at less risk?
Right. You're right, Boyan, that anyone who's out in the community and dealing with the public is at higher risk. I don't think there is anything specifically that needs to be done. I again would encourage, if this is someone who is on prophylactic, greater factor 9 or whatever, keep up your prophylactic regimen, maintain good nutrition. But I don't think there is anything specific that the bleeding disorder community needs to do, because, as I said, this is not a community that is uniquely at risk or has a higher risk of developing severe disease.
Thank you. I think we can move on to the next question, which is, if you're an older patient with HIV, are you at higher risk for severe disease? How should you manage?
Right. I think if you're an older patient with HIV, your main risk is your age and not your HIV. Certainly, you better keep up your antiretroviral regimen. Don't interrupt the regimen. This is not a time you want to let your immune system start to fail. But immunodeficiency, you know, even patients with other forms of immunodeficiency, other autoimmune diseases, there have not been reports of those being excessively represented in more severe COVID patients. So I think the key word in that question is older and not HIV.
Okay. Next slide, please. All right, now we're going to move on to questions around clotting and thrombosis. So what are the risks for patients on gene therapy I should say potential risks, fitusiran, emicizumab, or also known as Hemlibra, or longer-acting factors for hypercoagulability/thrombosis.
Right. So, you know, the hypercoagulability and thrombosis risk, those are relevant to people who are sick with COVID-19. So if someone is in hospital and has had gene therapy, look, there, as you know from some of the gene therapy trials, there were a few patients who reached higher than normal levels of factor VIII. So if you have, you know, this would be a very unlikely scenario, but if someone had an experimental gene therapy with factor VIII, had supranormal levels of factor VIII to begin with and developed severe COVID-19, that person might be at higher risk for thrombosis. That is an unlikely scenario. With respect, fitusiran is an experimental drug. There aren't many people in Canada on that drug. There are some. It is long-acting, as is Hemlibra, emicizumab. Those drugs do not cause a hypercoagulable state themselves. I would not anticipate that those would be increased risk factors for thrombosis. They do have a long half-life of about 28 to 30 days, but I would not anticipate that those would be risk factors for thrombosis, nor would longer-acting factors, because again, we don't overcorrect coagulation. So we are not making these people hypercoagulable. We were just correct or partially correcting their coagulation system. So I don't think that is a concern.
Okay, wonderful. Now, next question is, how susceptible are people with bleeding disorders to the coagulation issues that many severely ill COVID-19 patients have? And then there are 3 sub-questions on this. I guess we can start with the first sub-question that specifies, which is, what is the clotting risk if a person with a bleeding disorder is infected and has levels of 100%?
So I guess what that question is asking is, if you have hemophilia A and you're corrected to, your factor VIII is normalized, or hemophilia B and your factor IX is normalized, what is your clotting risk? Your clotting risk is the same as any other person with COVID-19. I can't cite you the overall thrombosis rate in patients with COVID, but you would be no different from anyone else. Now, what we would not likely, though, if someone with hemophilia, say severe hemophilia A or B, was hospitalized with COVID, likely would not correct them to 100%. You know, we would probably just maintain the regular prophylactic schedule or do a lower level correction so as to not promote that risk of thrombosis unduly. So that's not a likely scenario, but if you're at 100%, you're like anyone else with the disease.
Okay. And then I guess you've somewhat answered this already, but if we're susceptible, how difficult would it be to manage? And I imagine your answer is that not more so, but I'll let you.
No, you're correct. Not more so. Well, it would be a little bit interesting. So let me put it that way. Let's, again, a hypothetical scenario. Someone with hemophilia develops COVID, and we would normally put those people on blood thinners, preventive blood thinners, or if they had developed a clot, full dose blood thinners. In a scenario like that, let me give you an analogy. When we admit patients to hospital for major surgery, like joint replacement surgery, we completely correct their hemophilia, correct to normal levels of factor VIII or factor IX. We do give those people, while they're in hospital, we do give them blood thinners, which is done for everyone who has a joint replacement. So if someone were quite ill with COVID in hospital and we were replacing factor VIII or factor IX to normal or near normal levels, yes, we would give them blood thinners. Is it difficult to manage? We do it. We've got experience doing that. We've got people with mild hemophilia who we have on blood thinners for other reasons day to day. So it may sound odd and it may sound counterintuitive, but we have lots of experience giving anticoagulants, blood thinners, antiplatelet drugs to people with bleeding disorders. So it requires experience and skill to do, but we can do it.
Great, thank you. And then the third sub-question here, getting a little bit even more granular, should we continue to take factor, TXA, DDAVP, et cetera, if we are ill with or suspect COVID-19? And you've answered the factor question, but I guess the more specific DDAVP and TXA.
Yeah. I think if you, my first point I would make is that if you are ill or you feel you might have COVID, then contact your hemophilia treatment center and let us give you individual advice. In general, don't interrupt your treatment schedule. You know, again, you can think of scenarios if someone was treating aggressively for some kind of bleed with both replacement therapy and tranexamic acid and developed COVID, we might say, you know what, that's a little bit aggressive for someone who might be at risk for thrombosis, so we might want to dial that back a bit. But I would not want to make that advice generic. I think we would need to look at individual scenarios and we can give you advice. But in general, don't interrupt your regular prophylactic schedules. If you're bleeding, you need to treat and you want to prevent bleeding.
Makes sense. Thank you. Next slide, please. So now moving on to accessing care and treatment. So if COVID-19 is suspected, how can people with bleeding disorders prepare for a visit to the hospital?
Well, that's a good question, and I guess it depends. It depends where you are and how and what your status is. I think if you've got, for example, if you're on home infusion and you've got home supplies, you may want to bring them with you. For example, if you're at a hospital that's not a hemophilia treatment center, that hospital there may be a delay in getting treatment products, so it's always good if you can bring a few doses with you. Make sure that you always bring with you your identification card. We issue credit card type ID cards here at our HTC. Others will use factor first cards. Whatever your hemophilia identification wallet card is, make sure you have it with you. I think it's a good idea for you, again, to call ahead to your hemophilia treatment center. Let us know. Even if you're going to another hospital, let us know so we can communicate with the healthcare facility you're visiting and help to provide advice for care. So keep us in the loop. Make sure you have proper identification and that you're able to provide this information to the people who are treating you.
Okay. Now, this next question revolves around basically some of the ways that hospitals have been adapting to not being able to see patients or wanting not to see patients and bring them into the hospital needlessly. So if you have a virtual appointment, how can you get the most out of it?
I think the first thing, I'll repeat what I said before, is keep your treatment records up to date. So, you know, when we see you in person, we'll open up, usually in the room with you, we'll open up your My CBDR and we'll go over it with you and talk you through it and talk about it and see if your treatment regimen looks good. We can do the same thing on the phone. So make sure that you've got that you know what your treatment regimen is, that you've got your diaries up to date. Write out your questions beforehand, and so you can talk to us on the phone. Some people are using video calls. We haven't been doing that yet because not everyone has the equipment available to do it. And in most of the things that we can talk about, we don't necessarily need video to do it. We need audio. We have been having nurses speak to you. We've had the physicians, Dr. Scholzberg and I speak to you here at St. Mike's. Our physiotherapist, Lawrence, has spoken to patients. So we can talk you through all this. Having trouble with your diaries, we have our data experts speak to you. So I think we can give you lots of information over the phone, but you know, we can't do everything over the phone, and the clinics are open. And if you need to be seen, as I'll repeat what I said earlier, don't be afraid to come down to hospital. But keep your information up to date, write down your questions, and we can be efficient in talking you through it on the phone.
Okay, great advice. The next question is pretty highly specific, and it's around shifts in production for medications in general. So it says here, will there be any supply chain issues for factor products if and or when COVID-19 therapies under development prove successful, i.e., how will factor supply be impacted when there's widespread production and distribution of, they use the example of convalescent plasma, antivirals, or vaccines for COVID-19?
Yeah. I would not anticipate that that would cause any interference with supply chain for factor products. First of all, antivirals and vaccines, you know, hopefully we have those in the foreseeable future. Those are not part of the blood system, of course. Those will likely be distributed through pharmacies and through other methods. Now, convalescent plasma, if that proves to be a valuable therapeutic, that of course will be distributed through the blood system. But we've got a very robust supply chain for hemophilia and other bleeding disorder treatment products in this country. And I don't see that that is going to be stressed. You know, convalescent plasma is something that is relevant to people with very severe active disease. We're hoping that as we've flattened the curve and as the number of active patients in the hospitals will slowly decline, that that's not going to be a major stress on the system. And when we do hopefully get vaccines, that will be that again should not stress the supply chain for factor concentrates. So the kind of things that I mentioned earlier, the transportation links, the potential reduction of output from production facilities, those are more relevant, I think, than these other potential therapeutic agents.
Okay, that makes a lot of sense. All right, next slide. Now, some additional questions. One that I've gotten as well in my capacity as in my job at Hemophilia Ontario, which is the nasal swab test, especially for people with von Willebrand's. Could bleeding result from the nasal swab collection? And then what I would add to that, how do you prepare for that if there is a high likelihood that you will have a bleed caused by it?
Right. Yeah, I think that's a good question, and I think the answer is it could. I haven't had a nasal swab, so I don't know I can't speak from experience. So there may be people on the call who have, but you know what you've got to do is you're dislodging cells from the mucosal surface, because it's from the cells that you get the DNA or the RNA rather, of the virus. So yes, it can be forceful. So if you are prone to nosebleeds, as you pointed out, Boyan, a lot of von Willebrand patients are, and if you have DDAVP at home, you're a user of DDAVP, or you've got tranexamic acid at home, I think if you're going to have a swab, it's a good idea to take a dose in preparation for that. If you have hemophilia, then and you're due for prophylaxis, take your prophylactic dose or take an extra dose before you go in for that. So I think that would be a reasonable precaution. I've not heard of that being a problem, but it makes sense.
Yeah. There has been some concern from people, so it's good, I think, to get that reassurance and strategy for it. Now, on the other side of that, could intense or repeated coughing as a result of infection, so I'm assuming in severe cases, result in internal bleeding in the lungs or trachea?
Yeah, well, not likely trachea, but you know, COVID-19 is a lung infection primarily, right? It's a systemic disease, but the major effect is the lungs. It's a pneumonia. And some people with COVID-19, I'm not talking about bleeding disorders now, do cough up blood, so that can occur. And if you have a bleeding disorder, I pointed out that case of that man in China. He was not coughing up blood, although he was coughing. But sure, it can occur. You know, any blood you cough up looks very dramatic. It is very unusual for people to cough up enough blood that it's actually a risk to them. In other words, a small amount of blood looks dramatic, but usually it's only a small amount of blood you're coughing up. But if someone is coughing up blood, or if someone with hemophilia or a bleeding disorder is severe enough to be hospitalized, we will likely be, as I said, replacing them at least partially, and we can usually deal with it. So yes, it can occur. Bleeding from the trachea is not likely. That's usually would be some trauma would usually cause that.
Wonderful. I think that's it for the sent questions, and now we'll move on to live questions and answers. So I'll be reading out from the list we've gotten here, so bear with me. Now, if you're hospitalized because of COVID-19, should we insist on being hospitalized at our HTC hospital? Does the clotting factor level need to be actively monitored if you're hospitalized for COVID-19?
Right. You know, I think our preference is that someone who has a bleeding disorder, our preference is that if you need hospitalization, we would like it to be at your hemophilia or a hemophilia treatment center, because we would probably want to follow in fairly real time your factor 8 or factor 9 level. Now, if you've got a mild bleeding disorder, it may be different, but someone with, for example, severe hemophilia or von Willebrand disease, one of the things that we would be following closely would be factor 8 or factor 9. And most hospitals that don't have hemophilia treatment centers can do that, but with a lot of delay. It may take them 2 days before they get a factor 8 result. That's not ideal. So ideally, yes, it would be better to be hospitalized at a hemophilia treatment center. I don't think it's necessarily, it's not a make or break, because as I pointed out, bleeding is not a major concern in most people with COVID. And in any case, any hospital can do a PTT, which is a screening coagulation test, which can be used as a surrogate for factor 8 or factor 9. But if ideally people who are quite ill, we prefer that they be in a hemophilia treatment center if possible.
Okay. Next question is, to visit the clinic, do I need to come in with a surgical mask and gloves?
Well, I guess what I have to say is that different hospitals will have their own regulations. Someone who comes to our hospital, everyone will be masked when they come in, not gloved. We don't, you don't. If you want to wear gloves, you can if you've got them with you, but I don't think it's necessary. But masks, yes, and people who come in will be provided with a mask if they don't have one. Our clinic is open, regular hours, and lots of room because there's no one up there except except the nurses and our clerical people. And during clinic days, I'm up there maybe with one of our residents or fellows, but very few patients around. So you don't feel that you're going to be coming into a crowded area where you're exposed to a lot of. We have a lot of capacity, and make sure that you're kept safe.
Great. So the question here is, you primarily focused on hemophilia during the talk. Can you speak a bit to the impact of COVID-19 on people with von Willebrand? Yeah,
and I guess I did refer mainly to hemophilia, but really when I said hemophilia, most of what I said is applicable to any kind of bleeding disorder. Most people with von Willebrand disease have a fairly mild bleeding disorder. There are some who have severe bleeding disorder, but most of it is fairly mild. And most people with typical, what we call type 1 von Willebrand disease, if they had COVID, they would not likely need any specific treatment. And in fact, what I imagine we would see, what I predict we would see, is because of the stress of the illness, their factor 8 and von Willebrand levels would probably rise somewhat. And so it's not likely that they would need specific replacement therapy. Now, if the levels were fairly low, we would again have to individualize it. So if you imagine a case of someone who had fairly low von Willebrand levels and needed, say, a biopsy while they were hospitalized, we might give a dose of DDAVP or a von Willebrand concentrate to cover that procedure. But in most cases, I don't think von Willebrand disease would cause much in the way of complications for that hospitalization. unless it were a severe variant of the disease, which is a pretty rare illness.
Okay. Not to complicate it further, I think there's something that's generally not understood in the von Willebrand community too, is the fluctuation of von Willebrand factor that's situational. And you mentioned that because of the stress of the illness that the von Willebrand factor might go up, but I think that would be worth explaining why that happens in some cases.
Right. Von Willebrand disease, or von Willebrand factor rather, like factor VIII, tends to rise under stress. Now, if you have type 1 von Willebrand disease and a mild deficiency of von Willebrand factor, that same physiological rise does tend to occur. It may be blunted, but it does tend to occur. If you have severe von Willebrand disease, that won't occur, and you may need replacement therapy. But as you correctly point out, Boyan, if you've got typical type 1 disease during a time of, should you be unfortunate enough to develop COVID, it's likely that your levels would temporarily rise above their baseline.
Okay, great. We've got another one coming in here. It's again around thrombosis. Is someone with hemophilia less likely to develop blood clots or thrombotic complications from COVID-19 than the general population?
Well, it's a good question. I'd like to know the answer to that. The answer is probably on balance, yes. And having hemophilia is not like being on a blood thinner. If you have hemophilia, you're deficient in one clotting protein, and the blood thinners work in a different way, and tend to block, give a more robust block of the blood clotting system. However, if someone has, say, severe hemophilia or severe von Willebrand disease, and we replace them only modestly, not to full normal levels, one could hypothesize that would probably reduce the risk of developing blood clot. Nevertheless, as I pointed out earlier, we would probably still judiciously use anticoagulant blood thinners during the hospitalization, but that's something that would have to be individualized and would require the hemophilia experts and thrombosis experts working together to take care of the individual.
Great. Now, next one coming in, if you're waiting to enter a clinical trial, when do you think the pause on recruitment will end?
Yeah, that depends on the trial. So, one of the trials, for example, that we're involved in, we had word earlier this week, or maybe late last week, that they're now going to reopen recruitment if the institution is willing to do so. So it really depends on the sponsor of the trial. So I don't think we can give a generic answer to that, but some trials are starting to reopen entry. Of course, people are already on trials. We've had to adjust that too, and we've had to get approval, for example, to do telephone follow-up instead of in-person follow-up in some cases. So there have been adjustments made to the clinical trials.
Okay. Next one coming in is St. Mike's specific question here, taking steps to work with CBS, Canadian Blood Services, to have factor delivered to patients? Are other clinics moving in that direction?
I am not aware that there's been, that we've worked on. I guess that's asking about home delivery. Might product be delivered to patients' homes? And I am not aware that has been done. That's just has never really happened yet in Canada. We've talked about it, and I know some of the companies would be interested in doing it, but it's not necessarily up to them. The blood system and Canadian Blood Services and Hemophilia-Québec in Quebec run the system, and they have not incorporated that. So I'm not aware that that's done. We certainly are flexible enough. We can send product to other hospitals. It doesn't have to be at the Hemophilia Treatment Center. We issue product from hospitals all around the Southern Ontario, so we can change that very quickly if need be. People can pick up product on behalf of someone with hemophilia with appropriate identification. So we have that degree of flexibility, but I'm not aware of any home deliveries. And
Yeah.
someone can answer that. Boyan, you may have more information on that.
I do have a little bit more information on that one. I know that Canadian Hemophilia Society is currently working and has been in contact with Canadian Blood Services to try to negotiate that, and some developments on that may be forthcoming. As far as Hemophilia Ontario goes, we recently had an ad hoc situation where Mackenzie, the nurse at St. Mike's, reached out to us to mention that she had arranged a parcel for an individual patient under certain circumstances and asked whether we would be able to provide any kind of services with that. And since then, I've reached out to the courier that tends to be used, and we've made a preliminary agreement with them that future deliveries of that nature will be charged to us directly, and we're trying that out as a pilot. Like, this is something new to us, so we're going to be moving slowly, and we will see if that's something that is able to grow past St. Mike's. But for now, we're doing a wait and see approach to fill in some of the information there.
Very good.
Now, we've got another question in here. There's a correction to it. Is there any extra guidance for people with hemophilia and inhibitors? That's a good one.
Most people with chronic inhibitors now, long-standing inhibitors in Canada, are on Hemlibra or emicizumab, a drug we referred to earlier. So I would say just continue on your regular. Most people inject it weekly. Some people every 4 weeks. Don't interrupt the schedule. Does not cause excessive. Shouldn't be concerned about that. Who are on immune tolerance induction, don't interrupt your immune tolerance induction regimen. Continue to treat. We're not rendering you hypercoagulable. And if you're using bypassing agents, niastase or FIBA as needed, continue to do it. So I would say continue your regular regimen. Don't be concerned about putting yourself at risk. You're not.
Wonderful. And I'm being told here that that was our last question. Time flew by. We're at 6:06, which was the time we were supposed to wrap things up. So if we weren't able to get to your questions, I'm sorry. It was great to be able to get all of those questions. We were worried earlier that we might not get enough, but I had an inkling that this might be the case. And it's been great to get so many, and a lot of them were great questions. Thank you, Dr. Teitel, for taking your valuable time and being here with us to answer these questions. I know it's appreciated by the community. I think it's very important for people to be able to hear this and to adjust their expectations and to learn how to approach things at this time, because things seem to be changing every day.
My pleasure. Thank you for letting me do it. And again, thanks to Novo Nordisk for their support as well, Boyan.
Thank you. And I'll say from Hemophilia Ontario as well, thank you to Novo Nordisk, who sponsored the webinar, and the support is much appreciated. Last thing I'd just like to say for housekeeping is just a message for our membership for Hemophilia Ontario to let you know that now that more than ever, we're dedicated to serving the community and giving our support. Unfortunately, we aren't mind readers, and we can't tell exactly what you need. We are trying to fill those needs, but we would love to hear from you to let us know what kind of supports. Are there more supports like these webinars that we can provide you? Based on the response today, I'd say, yeah, that was a hit. But we'd love to hear from you. We'd love to know what we can do for you, and we can work on putting things like that together. So please reach out to us. Again, as I mentioned earlier, you can reach out to me directly at bpearnat@hemophilia.on.ca. And don't worry about if you heard that correctly here. It's also in the invite that we sent. It's on our website, Hemophilia Ontario. Also, any unanswered questions, if you really want answers to those questions or are looking for help in getting those answered, please send them to me again, and I'll do my best to connect you with resources, or if there's a theme to them, we may try to organize a webinar to try to answer questions around that specifically. I think that takes care of today. Thank you, everybody, for attending. Thank you, Dr. Teitel, again for being here. And
keep safe.
You too, and everyone out there. Bye-bye.